Good morning and welcome to the Health and Adult Social Care Scrutiny panel meeting. We have some apologies from Councillors Eastwood, Smith and from Sharon Taylor, the co-optee on the panel. Does any councillor present have any interest they wish to declare? Or any co-optee have an interest? No? Thank you. Do we agree that all items can be discussed in public? Thank you. Right, the first item, the minutes of the last meeting will be tabled at the next panel meeting in the next municipal year. I just want to record that following the discussions last time on the social care consultation, the concerns of the panel were looked at by the social care officers. We had some further consultation materials that were circulated by email that the panel looked at, and I met with the consultation officers to go through our concerns about the materials. The consultation was put back a week following the scrutiny meeting, and that consultation has now started with consultation materials that were discussed with us. Okay, right, we will review the work programme for this year then. We have to look at what is still a priority. Is there anything else we would like on the work plan? What is complete? And what are things for monitoring? Okay, all right. So the first item we looked at was the financial position of the CCGs. And we have had some meetings in that regard, and we agreed to maintain a focus on the finances of the health and social care system in Kirklees. Do we think that that should continue monitoring that financial situation, or yes? Yes, okay, we will continue to monitor that.
So just to clarify, it's the health and social care system. So in the issue column, should it include the local authority in there?
Yeah, we'll change that to be the health and social care system financial. Yeah, we'll change that. Okay, all right. The joint strategic assessment for Kirklees. We had a panel meeting in December. We requested further information, and we had a written update on the IAPT services. We looked at the Kirklees Health and Wellbeing Plan as well, and the STP as part of that. Now, the STP obviously is ongoing. There's work both at Kirklees level and work at West Yorkshire level. So it's whether we want to continue to look at the STP part of that. I think the joint strategic assessment is as it is, isn't it? It's updated on a regular basis. But it's whether the STP side of things we want to continue to look at any themes that affect Kirklees. What do people think about that?
Yeah, I think we should definitely look at the STP part of things, certainly for Kirklees, and I think that should remain on.
Okay, thank you. Right, the Healthwise Optimisation Programme. Now, we looked at that, we made comment, and the CCGs actually took an alternative way forward on that. So, shall we close that item down from the work programme? Any comments, Peter?
But it's really a case of where they're going to go with it from here. Presumably it's going to be included in the STP. And I think probably what we need to be assured of is that it doesn't happen by stealth. That people should be penalised because they weigh a bit too much.
Dave?
Yeah, I think the other thing is, as there may be something else that comes forward now, another proposal, which with a view to saving money. So we just need to keep an eye open for what that next item might be.
Okay, so if we put it as a lead member monitoring for now, but we'll put it in with the STP as well, part of the work plan, so it comes under that heading. Yeah.
It'll be interesting to to know about the outcomes, because yeah, if it's been approved, what impact has it had throughout its delivery?
Okay, so we'll look at that and put it under the SDP and look at outcomes. Maybe we want to look at outcomes in a sort of a 6-month time to see what's happening. Yeah, okay. Integration of health and social care. We had a couple of panel meetings on this, and we agreed that the focus on the integration agenda would continue to feature in the panel's forward work programme. I think this is going to be an ongoing conversation with officers on the integration, isn't it? Peter, do you want to come in?
Yeah, I mean, I think it becomes even more critical depending on the Secretary of State's decision.
Yeah.
You know, if we're to lose our acute hospital, we said it earlier, but who's going to pick it up?
Yes, I think, and also there's social care green paper as well, isn't there? That's due as well. So I think we keep that on as an item on the panel's forward work programme, as it is an ongoing piece of work within both health and social care. Right, CQC inspections then. This is where, if we have any inspections that we feel we need to monitor the results of. So we looked at Locala. We've had updates from others as well. Is it just an item that if there are any CQC inspections, we look to see whether we need to take any further in-depth look at them? Yeah?
Yeah, and just to possibly add on, once they've had their inspections, what changes again, what outcomes and stuff like that. So if they can come back in a few months' time and have an interim to see what they've actually made the changes out, so we're prepared before the next CQC inspection is going.
Okay. All age disability and adult pathways. We've received some updates on that this year. There has been some pieces of work that we've done, I think last work plan we did as well, didn't we? So we put that on a monitoring at the minute, and then if there's something that comes up on the under all age disability and adult pathways, we can pick it up as an individual piece of work. Yeah, okay. Healthy Child Programme, that is now up and running, and we had a panel meeting on the 12th of September to look at that. So do we feel that that item is can be closed, or do we want to do anything monitoring?
I think it'd be nice to have certainly some sort of like monitoring on that, on the Healthy Child Programme, just to, you know, just some ad hoc monitoring, just see where it's going and what the vision is.
Okay, we'll do some monitoring. We'll put it under lead member monitoring then for now. It's the CAMS, I think the CAMS side of things also we had concerns about, didn't we? So we need a discussion sort of at Scrutiny as to where that would, monitoring of CAMS would sit, because we were concerned with the cancellation policy, I think, according to the notes there. Yeah.
Could we possibly get patient review on that as well? Or patient feedback? You know, we'll get the practitioner's feedback, but it'll be interesting to see what impact it's had on the children that are benefiting.
Yeah, we can look at how it would do that. Okay. Right, integrated wellness model. We've seen that once on, well, we saw it a couple of times. And we're waiting for that now to come back. So we're just waiting for that, yeah.
I wonder, we're not duplicating what health and well-being are doing, are we, on that particular?
I don't think we were at that time. We were looking at the scoping and the specification. Certainly we wouldn't want to be duplicating the Health and Wellbeing Board work at all. So we'll make sure we're not. But we'll just wait to see what they come back with and see whether we need to look at it. Okay. Robustness of adult social care. We've looked at that a couple of times. And is there any further we want to look at that, or do we want to put that into the integration of health and social care item? Yeah? Yeah, Dave.
Yeah, I just think if we can also still keep a specific focus on the home care provision market and the state of resilience all round, so as long as that doesn't get lost. Those first 2 bullet points, really.
So we put that as a bullet under the health and social care system. Okay, so we don't lose that. Right. Item 10 then was the ADHD for adults. I think we were okay with that, weren't we? So, Peter?
Yes, I mean, I would agree, Liz. I mean, that scene, it seems that there's only quite small numbers involved. That doesn't minimise its importance. But it did seem that the consultant who came to address us, I think last year, I mean, what they were doing seemed to be going the right way.
So we can take that off the work plan. Mark that as complete. Okay. Right. Well, we list one item then. Okay. So, quality of care in Kirklees, that's the CQC's annual visit. I take it we want to continue for the CQC to come and see us, yeah. Suicide prevention, this we looked at in February, and we agreed to continue that on the forward work programme. Yes. Changes to podiatry services, they've had the consultation. We discussed their recommendations at the March meeting. We had a number of concerns about it. We have received some updates from Locala on that. Do we want to continue to monitor and look at the outcomes? We were particularly concerned, I think, about housebound, people who are housebound and the effect on them as well, don't we, Dave? Yeah.
Yeah, I think it'd be good to look at it maybe later on in the autumn, once implementation has actually started, and get a feedback on, particularly on the Age UK service as well.
I think so, because we asked, didn't we, that no service, Locala service was withdrawn until the Age UK service was in place. So they did.
Yeah, so what's going on that, just making sure that when they do come back, they give us more figures and information in terms of that, not just what we've got last time around. Yeah.
All right, mental health services transformation programme. I think probably there will be some items coming up under mental health services in the new year, so we need to keep that. On. Yeah, I've got a briefing on Friday. Yes. Care closer to home. This was assessing the effectiveness of the care closer to home contract in relation to the whole of Kirklees. The Joint Health Scrutiny Panel looks at it in relation to the changes, Condon and Huddersfield changes, but this panel looking at effectiveness for the whole of Kirklees. What does the panel, do we want to maintain a new view of progress? Peter?
Yeah, I mean, I think again it fits into it fits in with the STP, it fits in with the integration of health and social care. And looking to the future, I think it's pretty critical that this works, whatever happens.
Yes, and I think the effectiveness of the care closer to home as well, in relation to helping with winter pressures as well, because if you know, the care closer to home is supposed to help with the demand on the hospitals, and we need to make sure that that is actually the outcomes that are actually being achieved.
Well, I did think, and I don't know if colleagues agreed, that Locala was more informed about the level of activity that it's actually now delivering than when we first saw them. And so, you know, I think we can be optimistic about it, about the way it's going, but nevertheless, we still need to keep an eye on it, I think.
So do we want to look at that again and also maybe add to that as well, have it as a time in the work programme where we can look at the readiness for winter, although they're saying that they have pressures all year round at the moment, don't they? But effectiveness for the winter pressures and the care closer to home. We had a discussion in January, didn't we, about how they were coping with the winter pressures. And I think then we were saying we'd want to know later on how the outcomes from that and what learning had been achieved and what they were going to do moving forward. So I think perhaps we could do that all together, yeah? Okay. The Better Care Fund, we had an update in December. Now, that could probably go in with health and social care integration and the SDP and everything, couldn't it? Yes. Keep a monitoring on the Better Care Fund. Okay. Interim changes to hospital services. This was about the acute inpatient elderly medicine, cardiology and respiratory service provision at CHFT. And what we've got outstanding for that is we said we'd go and visit to see how it was, how the implementation was ongoing, and so we need to. They have come back with some dates, haven't they? But they weren't.
We have to leave it till after.
Yeah, they weren't suitable. So we will move that visits into the new municipal year. Okay, all right. Okay. Care Act, then that's just a monitoring, yeah. And the deprivation of liberty standards, again, that's a monitoring. Okay. TB, we've had some updates in October of last year, and a written update. Yeah, and we had an update in January, and we agreed that no further actions were required at this time. All right, so we're to close that one down. Okay. Review of mental health assessments. Now, this was the review of the ad hoc that we've done, and we've at the moment we've a piece of work, informal piece of work ongoing on dual diagnosis. And we're just trying to set up some more work on that, aren't we, Richard? We're waiting for availability of Richard's time to look at that. We will be continuing with that informal work on dual diagnosis, because we looked at it, didn't we, Peter? And we had some areas we wanted to look at.
Yeah, I mean the dual diagnosis is thorny because people are definitely falling between two stools. Their addiction needs to be treated by one part of the system and the mental illness by another. And I mean, it did look as though, as though there was work to be done. Let's put it that way.
I would agree that definitely it needed work to be done.
That response to the update and recommendation
Yeah.
circulated to you, but hasn't gone out to the
okay. So we look at that dual diagnosis, and we look at it in respect of possibly bringing it to a panel meeting as well once we've done the informal work. Okay, And also we had an update on the recommendations from the Mental Health Trust, which will be circulated to the panel. Okay. Wheelchair services, we agreed that we'd arrange a meeting with UpCare, so we will sort that. And then item 23 is carers in Kirklees, and I was looking for a focused piece of work, and that would be task orientated, so it would be a short piece of work, and we were looking to scope that out, and so we'll continue to do that and have discussions as to how that piece of work can be carried forward. Okay. Right. Is there anything else?
The reports that come back next year, would it be possible is certainly the key topics and things like that we get some real information, not just like green smiley faces from a patient survey or something like that, because some of the things that we've had this last year, I feel the information has been a bit limited, so going forward, if we can just emphasise that to any of the partners. Thank you.
Certainly we can do that. Dave,
Yeah, I was just wondering, given there's 20-odd items that we're considering, and it's over several pages, I wonder whether it's possible to have a single sheet which shows each of the items, perhaps grouped together where it's relevant. So we picked up on a couple of CQC items, for example, the inspections and then the kind of overview. So at a glance, we can sort of see how the areas relate to each other, because that's the bit I find it more difficult to get my head around, how each of these 20-odd items fit together. If it was possible to do it on one single sheet, just a very sort of brief summary, that would be great from my point of view.
we can look at a flow diagram then. Peter?
Richard's looking really pleased.
Yeah, I'm not wanting to fit it up with more work, but diabetes seems to have slipped off the list, and given its prevalence in our part of the world, I'm not begging for more to do.
Yeah, we'll have a look, see if there's anything we can look at on diabetes.
And I think in particular what we didn't cover when we looked at it last time is how good are we at controlling diabetes. Knowing people have got it is one thing, but being able to control it, for which there are various serological tests.
Yeah, okay, we'll have a look at that and see if we can scope a piece of work on that, okay. What we do is with the work plan then, we circulate it to social care officers and the CCG and ask for any items that they feel also should be, scrutiny should be looking at. And so we will do that, okay, all right. It has been a long work programme this year as usual, and there's been items that we've had to put on at short notice, and items that we've had to deal with by email as well, because of the time that we needed in. And so can I thank you all for that work, because I know it has been quite difficult this year, quite a lot of information coming our way. We also get the quality accounts at a time when we don't necessarily have meetings, and they are quite thick documents to look through. So thank you for taking time to look through those, because we do have to respond, certainly on the CHFT, where we need to respond on that one, certainly. Okay, all right, thank you. So we'll just be a pause while we just, before we... Okay, the next item on our agenda is the Care Quality Commission, and we have a regular annual visit from the CQC to inform us of progress in inspections in Kirklees. We have a number of people here from the CQC. If you could introduce yourselves to start with, that would be good. And we also have people from social care as well, if you could introduce yourselves. Okay?
Okay, I'm Helen Harris. I'm Inspection Manager for Kirklees for Adult Social Care Directorate.
I'm Jenny Jones. I'm Inspection Manager for the Hospital's Mental Health Directorate. I am here standing in for Kate Gores-Brightmore.
I'm Jonathan Weeks. I'm an Inspector in the Dental Directorate, part of the Primary Medical Services for West Yorkshire.
Good morning, I'm David Ross. I'm Inspection Manager for Primary Medical Services across West Yorkshire. My team cover GP practices and independent consulting doctors.
Hello, I'm Amanda Evans and I'm Service Director for Adult Social Care.
Morning everyone, I'm Saf Boot. I'm the Head of Quality, Safeguarding and Performance for Adult Social Care.
Morning everybody, I'm Simon Baker. I'm Head of Commissioning Adult Services.
Thank you very much. We have a presentation from CQC that you're going to run through, and then we'll take questions after the presentation. Okay, thank you.
Okay, so I've already introduced myself. I'm Helen Harris. I'm Inspection Manager for the Adult Social Care Directorate in Kirklees, and that means that I'm responsible for the folio services, so that includes community services, domiciliary care, supported living services and residential and nursing services in the patch. So I'm about to present to you information, a bit of contextualising where we've been in the last few years, moving forward about where we are now, and some common themes really about what we're finding from inspection in the patch. I apologise for the typo, mental health hospitals. That should read mental health hospitals, so sorry about that. Okay, can everybody hear me all right? Is that?
Yeah, it's more important for the webcast.
Yeah, okay, all right. So, I'll start with the context here, which in 2015-16 we produced a State of Care report, which was our initial findings from our new approach. And I don't know if you're all aware, but we changed our methodology in line with the Francis Inquiry findings. And we came up with a method of our new approach to inspection, which was very thorough. It was based on key lines of inquiries under the domains of safe, effective, responsive, sort of caring, responsive and well-led. And we moved to a system of ratings. And I think that at that time what happened was it was a wake-up call to providers in terms of how they had previously gone about things. And because our way of actually holding to providers to account through this new methodology was more rigorous and a lot more thorough, because before we would use maybe we'd look at 5 of the fundamental standards, and now we move to looking at all the regulations through our new approach. And consequently, nationally, the picture was that we were finding lots of inadequate services, or certainly more failing services than previously. And so the State of Care report for 2015-16 was talking about a tipping point, because there was a pressure from ourselves in terms of a much more robust approach to our inspection, but also a rising demographic, particularly with and we still have that within the older age group of older people with increasing needs. Also at a time with austerity beginning to bite really in local authorities. So I think that it's important to think of the context that we were in, and actually through the course of this presentation I'll sort of take you through to a sort of the present picture. So those are some statistics on that slide about the pressures that were in the system. And part of that pressure was also, and is still also, about nursing provision. And in the last year we've had one big nursing home close, that was Woodlands, and we've had a succession of other closures in residential care as well. And I think that has squeezed the market. Nationally, there has been a 4% reduction in nursing homes and also residential homes, 4% reduction. Community services, though, have increased by 5% nationally, and that's we are following that trend within the provision in this local authority. Actually, the pressures around a lack of nurses is having an impact on nursing home provision. But with that, I think people are wanting to stay at home for longer, and people are managing to stay at home for longer. So that, in tandem, increases the market drive for the demand for community services. So last summer, we signed up to an action plan, a strategy around, which is called Quality Matters in adult social care. And this is a very important marker in understanding what quality means for everybody who's involved with provision of adult social care services, not least people who use services and their families also. And it's been a broad coalition between a range of improvement organisations such as SCIE, Social Care Improvement, ourselves as the Care Quality Commission, Skills for Care, Carers UK, ADAS, Healthwatch, and all with a mission to improve person-centred care. And I think this has been born out of the tipping point in the earlier slide that I was talking about the fact that we were approaching a tipping point in the market and the provision, and with austerity and all these things coming together. And I think that what Quality Matters has done has provided a conversation where we're all speaking the same language, and actually partners across a range of aspects of the provision of adult social care are coming together and have signed up to an action plan, and we're included with that. And key in that action plan for us is around how we drive improvement through our regulatory responsibility, but also how we're encouraging intelligence and responses around complaints within our responsibilities as well. So basically, Quality Matters is about shared understanding of what high quality care is, about more effective and aligned support for quality in adult social care, and improved quality which we can measure and celebrate so that care is consistently high quality even when no one is looking. And it makes a real difference to the lives of people who use services, their families and carers, because actually adult social care, of all the directorates in the Care Quality Commission, we have the highest number of locations and ultimately the highest number of people who are in receipt of care in their home. So the CQC has set out its 4 priorities to achieve strategic ambition. And these 4 priorities are to encourage improvement, innovation and sustainability in care. And we will work with others to support improvement and adapt our approach as new care models develop and publish new ratings of the services as we go through our inspection schedule. One of the things that we have developed since 2050, I think it is an approach to special measures, so that when we inspect services in adult social care and they are in inadequate rating, we will place them in special measures, and that means that within 6 months we will be back. Within 6 months of publication of the report, we'll be back, and we need to make sure that those services have improved in that time. If the service does not improve its rating and lift itself out of inadequate, then we will consider cancelling that registration for that location, or take steps to consider cancellation. So that is something that's built into our methodology. So it's not saying that we will cancel the location after a recurrent rating of inadequate, but we have to strongly be able to justify why we wouldn't do that if a service has failed to improve. So that's all part of how we encourage improvement, but also at the other end of the spectrum, where we find outstanding services, then we want to celebrate those services and hold a light to them, really, so that other providers can look at what that care looks like. Now, some of the outstanding services on our patch in Kirklees were the hospices. And actually, the hospices have moved directorate now, so they're out of our remit, but certainly, so they've gone to acute hospitals, I believe.
We've gone to hospitals.
Yeah.
It depends which organisation with us to which practice.
Ah, right, okay, yeah. So it's dependent, but certainly there's been a lot that actually mainstream adult social care can learn from, even hospice outstanding services. So the second priority is about delivering an intelligence-driven approach to regulation. And this is really about thinking about how we are liaising with partners and the public, and internally how we're generating intelligence about planning for inspection. And my inspectors regularly contribute to a chess meeting, which is with the local authority hosting, and it's with a range of partners who come together at that meeting to be able to discuss issues of concern, so that we can operate an early warning flag on services that are, worrying, and that we can then go out and be able to inspect and be able to be assured that either things are okay and we've no need to worry, or we need to take action to be able to ensure safety of people. We now have a much more in-depth analysis of data that comes to the inspector as part of the planning for inspection, and that helps because really any inspection is only as good as the planning that happens before it. So it's about being able to use that intelligence in a much more focused way. But also we have, because our profile has increased as an organisation, and I think that's something that my colleagues probably would agree with me in terms of David Behan's leadership of the organisation, has really turned our reputation around and profiled us in a different way with the public, which means that the public feel able to come to us and share their intelligence, which means that we're in a stronger position to be able to respond accordingly and use our regulatory powers to be able to make sure that people are protected. The third priority is promote a single shared view of quality, and that relates a lot to what I was discussing previously in terms of quality matters, because essentially we want to make sure that services are person-centred and that quality is something that is upheld and understood by all partners, and that there is shared language about that. And I think that our inspection method in adult social care has really provided some pillars of understanding about what quality should look like. And that's part of having a trusted quality product around our inspection report. And the fourth ambition is to improve efficiency and our effectiveness. We are in the middle of a cost savings drive to be able to generate cost savings, and those cost savings are ongoing until 2020-21, and they were initiated in 2016, and we're on a path, what the senior management are describing as a glide path. So it's very much a planned cost savings that are being made, and some of that saving will be made through an increase in fees, which is being talked about presently. But we aim to save 20 million over and up to of that saving will be a reduction in some of the inspections that we're carrying out, because we will be targeting risk much more effectively. So at the moment, since it came into force on the 1st of April, we are now changing our inspection methods so that if services are rated good or outstanding, they are now due for inspection not in 24 months but in 30 months. So that's a change. But having said that, because our intelligence is sharper, it means that if we are concerned in any way about those services deteriorating, then we would go out and inspect them as normal around any concerns around risk. So just want to say a little bit about changes to our approach. So that's the first change that's happened that I'm saying that I've shared with you, which came into play on the 1st of April around our good and outstanding rated services. From November, we had additional key lines of inquiry. And those key lines of inquiry, as I've said, sit under each of the domains of safe, effective, caring, responsive and well-led. And these have strengthened our position around equality and human rights, so that actually we are now mandated to have very strong conversations with providers about what they're doing to make sure there's equity of service provision for all people using services, and that they have a fluid understanding of the importance of a golden thread of equality and human rights running through their service provision. And there are 6 new key lines of inquiry, and broadly they encapsulate about how lessons are learned in the service, how safeguarding systems are deployed to safeguard people, how evidence-based outcomes relate to practice actually that's delivered in the service. We now have a key line which looks at the Accessible Information Standard, which became part of legislation live in 2015, which means that people who have difficulties in accessing information about their care, actually the service provider needs to be proactive, ensuring that they have that information presented to them in a way that they can understand that information. That there is a specific key line of inquiry around how the service is combating discrimination with respect to the Equality Characteristics legislation 2010. In well-led, there are 2 additional key lines of inquiry which consider now specifically about how they monitor quality, how the provider monitors quality in the service in respect of compliance with the regulations. And also a discrete, Chloe, around involvement and how the provider is actually involving service users and their nominated carers or loved ones in terms of feedback about the service, the quality of the service. From April 2015, we inherited the Health and Safety Executive powers to prosecute under Regulation 12, which is the regulation that looks at safe care and treatment. And fundamentally, this power is used where we have evidence that a provider has failed to take all reasonable steps to protect people in the service. And we were one of the first areas to take a successful prosecution forward, and that was a St Anne's service at Smithsmore Lane in the Patch, and that service was subject to a £190,000 fine on the back of our prosecution, and the situation, which is well documented in the public domain, was that a service user fell from a chair and subsequently died. And there were inadequacies in terms of their risk assessment and the way they were moving and handling. And so that's something that is affecting adult social care more broadly, because our resources are taken up with taking on criminal investigations to protect people. And the Francis inquiry quite rightly said that one of his recommendations were that we should inherit those health and safety executive powers for criminal enforcement within these settings, because obviously it sits very nicely with everything else that we do, but is an enhanced power that we have to be able to protect people and hold service providers to account. We are moving to a hub mode of working with a smarter use of resources. Now what that means is that so previously, when we have a lot of risk that's occurring in the patch, we were reaching saturation points at times in particular teams. And when you need to be able to respond, so if we're getting information from the local authority, we need to be able to go out and inspect services. But if all my inspectors are already busy with risk, then that's a risk in itself. Now what we're able to do is share intelligence across the patch and be able to deploy inspections within the West Yorkshire footprint initially, so that I can pull inspectors from the neighbouring teams to be able to go out and target risk. And that is something that we work in terms of discussing what the priorities and risks are, and we have a much more joined up conversation than previously was the case with my fellow inspection managers. I talked about the longer re-inspection times that's changed, that we have a more targeted approach now to requires improvement services where there are recurrent inspections, that is more than one, where we go back and that service still requires improvement as a rating. We will meet with the provider and we have an increased observation really about where that is happening, and we need to be able to review our regulatory position with those providers, because our mode is to improve service provision, and clearly if a service is recurrently requires improvement, then they're not actually moving to make those improvements. So that's something that's mandated now in our method in adult social care. So in terms of the overall picture, so in 2016, you can see that Kirklees, we had 1% as outstanding, 55% as good, 34% requires improvement, and 10% is inadequate. And that was lagging somewhat behind the national picture. So to our 55% as good, there was 73% as good for the national picture. Again, 10% behind in terms of requires improvement, 24% requires improvement in the national picture, and a greater rating for a greater amount of services that were inadequate, 10%, and against 2% the national picture. So in 2018, things have slightly improved. But what I can tell you is that we have some inspections that we've just returned to, and actually things are going to improve again, but that information isn't yet in the public domain in terms of the published reports. So that picture will continue to improve. So you can see that we decreased from 10% inadequate to 8.74, but that, if I was to pull off this information in another month's time, then it would be, slightly less, looking at about 7%, probably, approximately. You can see that the good services have increased slightly, and and the requires improvement have increased slightly. And the national picture has continued to improve. So these are the ratings just across the West Yorkshire footprint. I thought that would be interesting for you to see how we compared with the other neighbouring local authorities. So you can see that in terms of the good ratings of services, we're third out of 5. For requires improvement, we are the second highest out of 5. And in terms of outstanding, we're the lowest scoring. And the number of locations I put at the end there, so obviously the percentages skew slightly to do with the number of locations. The enforcement across West Yorkshire footprint. Now, this is quite a hard slide to read. I'm sorry about that, the way it's listed. But basically, the total on the bottom, that's the total of locations. It's not the totals of the numbers of enforcement action taken. But if I draw your attention to the cancellation of registration, which is 4, we haven't closed 4 services. Some services where we've taken action have then closed themselves before we've actually completed that action. And yes, that's happened on a number of occasions where the provider has just decided to sell because the pressures to make the improvements that we've demanded have been just too great for them in terms of their business ambitions. And other issues around staffing, particularly with nursing home provision. But that figure of 4 means that what's happened is we've issued a notice of decision to close, but that notice of decision did not get enacted because we went to tribunal, because we were going to go to tribunal, and actually the tribunal got stayed, and then that decision was rescinded, but on our system it's still registered as the decision. So the decision became issued, but then it was rescinded. So that's what that means there. So that's why that shows higher, but actually doesn't correspond with services that we've closed. So you'll see that the language compliance action, that's the least enforcement action that we can take. But compliance actions did change in language from 2016 and became requirement notices. So the language changed. So where you can see 68 compliance actions and 67 requirement notices, if you add those together, you get 135. So that's 135 in terms of the lowest end of enforcement that we can take. And that's where we ask providers to submit an action plan about what they're going to do to be able to improve the compliance in that service. Warning notice is the next highest enforcement action that we can take, and that's actually asking providers to, it's listing evidence about where we have problems in the service, and providers are mandated, legally mandated, to be able to put that right. And if we return to the service where we've issued warning notices and they haven't put that right, then we would look at an escalation of our action. I mean, I can take questions about this because it's maybe a little bit dry. So the key themes of concern, particularly, over the last year, we have the most recurrent breaches of the legislation are reported in Regulation 12 and Regulation 17. So Regulation 12, as I've mentioned before, is about safe care and treatment. So it relates to the provider's responsibilities to ensure that safe care is provided for people. And Regulation 17 is about the governance, the good governance in a service. And it's a requirement to make sure that quality oversight is very much present in the service, and that there are systems and processes to be able to assure the provider that quality is happening in the service. And it's no surprise that those key breaches are the common themes and they sit together, because actually if you haven't got compliance with Regulation 12, safe care and treatment, then actually the service isn't going to be well led. And critically, those two regulations sit mainly under safe and well led, although there are, we can use that regulation in the other domains, but in the majority, those are the domains that those are concerning. So across the patch, the lowest domain rating was for safe, and that's true of the national picture also. And I think that one of the reasons for that is that we have the most key lines of inquiry under safe, and our analysis of what safety looks like is very stringent. So I think that we'll all agree that safety is paramount in services, and consequently our observation of what that regulation in terms of it being met looks like needs to be one of the most robust under our observation and inspection. Yes, I'm sorry. I know that why I've put more slides in, I should have said this at the beginning, is because I didn't attend last year, and so I know that people were wanting a little bit more from me. So, yes. Yes, thank you. So the key, yes, I won't be too much longer now. So where safe was inadequate or requiring improvement, well led was rated the same or lower. So where you had issues with safe, you would also have issues with well led in reports. And the recurrent themes and concerns were highlighted in the patch about a lack of staff and ineffective deployment of staff, and some of that related to the estate, because we have some care homes with older estate where it's harder to be able to monitor people, so staff have to be deployed at opposite ends of the building to be able to monitor people effectively. Changes and lack of registered manager, that those things where registered managers change at locations, it means that it's an additional risk for services to drop their ratings. And poor moving and handling practices, lack of meaningful activities. So often there may be an activities coordinator in some of the care homes that we visit, but actually making sure that people, that those activities are meaningful and actually relevant to the person themselves and what they wanted to achieve with their time was falling short. And a poor record of quality oversight. I think that with our new method, providers are starting to become alert to the more robust standards that we're demanding of good governance in Regulation 17. And often providers, particularly single-handed providers, they felt they had a grip on their governance by being in services, but actually that wasn't documented and formalised. So the improvements that we've noted, certainly staff now have a much better understanding of the Mental Capacity Act and what that means for people in terms of their basic human rights. The majority of services are improving from inadequate ratings, and we're still getting through some of those services at the moment. And what I've described is that it will be an improving picture from the 8% where we are across the patch at the moment. And dignity champions, and actually that's something that we've seen a lot more of across the patch, and certainly dignity and respect, which relates to Regulation 10, is becoming less of a feature in our enforcement action than was previously the case. Thank you. I'm sorry to have taken
Okay, thank you very much. I've just got a few 4 or 5 slides to take you through this morning in terms of what's happened over the course of the last 12 months since I last presented to you. So last time I was here, we had just finished the programme of rating all GP practices for the first time at the end of January 2017. And 2017-18 has seen our inspection activity focus on a number of areas. This includes inspections of new providers who were awarded their first rating since they registered with us. We've also completed a number of focused follow-up inspections where we've revisited practices where we found issues with the quality of care that was being provided the first time we went there. We've also completed some inspections for the first time of independent consulting doctors' services, and we've also inspected in response to risk. Now, across the Kirklees patch itself in 17-18, we've completed 17 inspections in total, of which 10 of those have been comprehensive inspections and 7 have been focused inspections. And the data on the slide that I'm presenting, the first slide there, the only information that isn't shown on the slide there is that there are, in addition to the current position of March 2018, where there was 1 service rated as inadequate, 62 good and 2 outstanding. What the data doesn't show is within those 62 services that are rated as good, there are 7 services which have 1 key question or 1 population group rated as requires improvement, but the rating for the service overall is good. So all that data presented there reflects the position as of the 5th of March this year, which was the date that the data was taken from our systems. So there will be some slight changes to that since then. But generally speaking, the picture in Kirklees is slightly more favourable than across the rest of West Yorkshire. What we found with our rated GP services is that 98% of those services are either rated as good or outstanding across Kirklees, as opposed to 96% across West Yorkshire. So slightly better than the picture across the patch as a whole. Okay, the next slide just gives some of the headline findings from our National State of Care report into GP practice and GP service provision. And again, as you can see there, generally the quality across GP services across England is pretty good, with 89% of all services rated as good and 4% as outstanding. And these services are provided to a total of 52 million people in total. We've seen some good examples of high-performing GP practices where they're collaborating with various other service providers, and also we've seen good evidence of them using non-traditional roles to support and reduce referrals to other services. Our main concern, which is very similar to some of the themes that Helen and the adult social care teams have picked up with their inspections, is that our main concerns with providers in primary care are generally with regards to the steps they take to ensure the safety of the services. So some of the main issues we've found can include things relating to poor governance systems, which tie into Regulation 17, processes to manage risk and to learn from incidents so they're less likely to happen again, and also poor leadership with unclear roles and responsibilities. And like all public sector services, GP services are no different in terms of facing the pressures of rising demand for their services. And this isn't always being matched by a growth in the workforce to meet these needs. This can lead to people finding it harder to access appointments with GPs than they have done in previous years. In terms of urgent care and out-of-hours services, which our sector of CQC also regulates, again, what we've found up to now is that 61% of these services were rated as good and 8% rated as outstanding in our first round of inspections. And again, some of the issues we found with regards to these services, with regards to the poorer care that we found, was as a result of challenges in managing patient demand and, again, recruiting and retaining workforce. So you can see there's some common themes coming through there. We've also inspected online service providers. So these are providers who provide services either remotely or digitally over the internet by means of either email or Skype consultations, for example. We did find some significant concerns with these services when we first inspected them, so we did prioritise the inspection of all these registered services nationally. I'm pleased to say that we are finding that although there are still some areas of improvement, things are improving quite quickly with regards to what we found the first time we went to visit these services. And another thing that was flagged up in the GP State of Care report, it was noted that there had been improvements in healthcare for children in the care of the local authority. So this is often referred to as looked after children. But we also did find that local organisations also needed to improve access to things such as speech and language and occupational therapies and diagnostic pathways for children with the autistic spectrum disorders. Okay, this next slide is something that Helen has referred to already, so I won't go into massive detail with this. It just reflects our ambition as an organisation to provide a more targeted, responsive and collaborative approach to regulation so that more people are in receipt of high-quality care. And one of the key things that's built into this ambition is about not just repeating what we've done in terms of inspecting as we have done over the course of the last 3 or 4 years, but learning what we've taken from those inspections and applying that to our methodology moving forwards, which will allow us to target where either poor care is taking place or where it would appear that there's been changes in the quality of care. So we're in a position to respond to that more promptly. Again, just reference to the 4 priorities that Helen talked through to help us to support us to achieve our ambition over the course of the next few years. And again, just focusing on point 3 there in terms of promoting a single shared view of quality. This is something that very much underpins the work that we do within the Primary Medical Services Directorate. We've built very good, strong relationships with both Commissioners of Services and also NHS England. And we do meet on a regular basis every 2 or 3 months with all of those parties across West Yorkshire to discuss the quality of services and any risks that are emerging across the whole of West Yorkshire. Okay, so as we sit here today, we're in the middle of rolling out our revised approach to inspection methodology, and this next slide just gives you an idea of where we're at in terms of what's already in place and what's still to come during the course of 2018. So if we wind back to June last year, first of all, and at that time we introduced something which we refer to as our new insight model. So this is something that we've already put into place, and this uses nationally available data to help our inspectors to monitor and understand what is happening out there in the land of primary care. And we always use this information as part of our evidence in our inspection reports. We also use it to support our planning activity around the inspections that we intend to complete. In November 2017, in the same way that Helen talked about previously, we introduced our new inspection framework. And this, for primary care and GP services, means that for providers who are rated as good or outstanding, we will return to inspect these providers within a 5-year period. So it could be at any point up in that time, but the limit will be within 5 years for these services. And we'll always inspect a proportion of these providers each year just to make sure that we're able to meet that objective of inspecting every 5 years. April 2018, so the last couple of weeks, has seen some further progression in terms of our new model rolling out. So what we've introduced in April 2018 is we refined our approach to inspecting and rating population groups, and we've also continued with the introduction of a shorter inspection report. So that we're not at the point yet where any of those will be in the public domain and be published. But essentially what you'll have is a report that is slightly reduced in length from what you've seen previously, but it will also be supported by what is called an evidence table. So that will sit alongside the report on our websites once they are published, and it will be the 2 documents together that will be used to formulate our judgments. And still to come in 2018, and this is all work that's still ongoing internally within CQC, we will be introducing a new system of what we're calling provider information collections for those practices which are rated as good and outstanding currently. So this information is where we will go out to a provider during the course of a 12-month period and ask them to give them a period of 6 weeks to submit some information to us. And then we will use that information along with everything else that we hold about the service that we've gathered from other sources, such as nationally available data, information that we receive from stakeholders, and that will all be used to complete what is called an annual regulatory review. The annual regulatory review can result in one of two things. If the inspectors assess the information that they have is indicating there has been a change in the quality of care that's being provided since we last inspected, so that can either be an improvement in the quality of care or it can be a deterioration, that can lead to triggering an inspection of that service. If the information that we've reviewed suggests that there hasn't been a significant change in the quality of care that's being provided by the provider, then we will just acknowledge that with the provider, and then we'll again revisit that provider information collection within the next 12 months, and again we'll go through the same regulatory review process until we get to the point in time where all providers will have been inspected within that 5-year time frame. And again, just the last point there, just later in 2018, we will be shifting to completing more focused inspections of good and outstanding providers. Up to this point in time, we've always conducted comprehensive inspections, but again, our monitoring of information and use of the annual regulatory review will help us to focus more on the issues where there appears to have been a change in the quality of care provided. Thank you very much.
Okay, so I'll give a brief overview of, because I wasn't able to attend last year, of how we inspect dental services, because it's very, very similar to GP services, because we're essentially a subsector of the primary medical services there. Okay, so the main difference is we only inspect 10% of locations nationwide each year. So this is because from previous work since inspecting dentists, we've identified them as being of a lower risk than other directorates. And similar to GP inspections, we take along specialist advisors, so that's someone who has a dental background when we do each of these inspections to provide that specialist input to the reports. We ask exactly the same questions as the other directors, so safe, effective, caring, responsive, well-led. And another big difference is we don't rate dental practices like all the other directorates. And the reason is because we only inspect the 10%, so we don't really know what outstanding would look like or what inadequate would look like. So when we do report on them, we say a practice is not providing safe care, as opposed to other directories where they would say the practice rated requires improvement for safe. And the dental team is quite big, so it covers a lot of area. So I personally cover all of West Yorkshire, and the area is the north, so covers from Sheffield up to the Scottish borders. I've got 8 team members, hence only inspecting 10% of these locations. I said, with the 10%, we always focus on risk, so that comes through as complaints from patients, whistleblowers, information from other organisations, so the General Dental Council, NHS England. So we're focused on risk. And currently we've got 66 active dental practices in the Kirklees area, and these are a mix of totally NHS, a mixture of NHS and private, and also these include orthodontic practices. Over the past 2 years, I have inspected 13 services, and that is again a mixture of NHS, private, and also orthodontists. And we've found that in the whole, that these services follow our national projection of 10% of services being in a breach of legal requirement one way or another. And on the whole, we've found dental services have been good, providing safe, effective, compassionate care to patients, which they've been very happy with. And the common issues we find in practices is, again, it goes a lot similar to what David was saying. the poor leadership within the practice, and no culture of learning from significant events, poor approach towards audits and quality improvement, policies and procedures not being regularly updated or reviewed and not being embedded within the culture of the practice, staff not being up to date with their training requirements, poor assessments of risk, so fire risk and Legionella and such things, and also a lack of awareness of robust recruitment procedures is also a very common problem that we find within these practices. But on the positive side of things, when we do identify issues, even if we don't provide a breach of legal requirements, the practice tends to be very proactive and keen to learn and take on board issues that we identify. And I've said more often than not, we find a lot more positives than negatives when we go out and inspect. So, as I mentioned before, providers are very responsive to feedback. So they're keen to improve, constantly improve, and take things on board and help embed anything in their practice. Staff, friendly and caring. Patients, we ask for patients to complete comment cards. We speak to patients when we go and inspect, and they always comment that the staff are friendly, caring, and couldn't go more further to help them out. Infection control procedures are good. We find that practices are clean, tidy, hygienic, and instruments are cleaned as they should do and follow nationally recognised guidance. Similarly, the treatments, when we speak to the dentists, they're aware of the guidance that they should be following when treating patients. Again, speaking to patients, they feel involved in the treatment. They can feel they can help make the decisions and mould the treatment to what fits best around them. And also feedback from patients, the registered patients, that they have good access to ongoing care. So if that's routine appointments, checkups, fillings, and also emergency care if they do need it. Because we don't rate dental practices, we do have something, if we identify something where a practice goes above and beyond, and we want to highlight it and shout from the rooftops that this is a great thing. So what we do is we have something called notable practice. So, for example, of a notable practice is where a dental practice, staff from dental practice go out to local community groups or brownie groups or cubs or toddler groups to provide oral health education to mothers and kids. That sort of thing is where we see where they've just gone above and beyond what we'd normally inspect or expect. And that is something we try and do when the providers get, I believe it's a monthly or a 2-monthly email that has examples of these notable practice, which is a really nice thing to see when we do it. And that's it for me.
The national picture for mental health for 2016-17, as of the 31st of July 2017, the ratings for the 54 mental health trusts were 4% of these were outstanding, 59% were good, 35% were requires improvement, and 2 were inadequate. That is quite an improvement on the previous year. The previous year we had no outstanding NHS trusts and only 34% were good, 64% required improvement and 2% were inadequate. So there's quite an improvement there. There are 2 outstanding NHS trusts. One of those is in East London and the other one is Northumberland, Tyne and Wear. South West Yorkshire Partnership Trust, which is in this area, or has some services in Calderdale and Kirklees, is rated as good overall and is good in safe, effective, caring and well-led domains and requires improvement in the responsive domain. And there have been follow-ups, inspections between November and February 17, and the report was published in April 17. I should state, though, however, that we are actually at South West Yorkshire Partnership Trust right now inspecting, so we are likely in the next couple of months to see a new report with new ratings. South West Yorkshire Partnership Foundation Trust has 10 mental health core services. 8 of those were rated as good overall, and 2 were rated as requires improvement. Those that were rated as requires improvement were the acute and psychiatric intensive care units for adults of working age and community learning disability services. The issues we found included long waiting times in some community services for working age adults, child and adolescent mental health services and learning disabilities. Access to records in the community learning disability services, and mandatory training and supervision in the acute and psychiatric intensive care units. The national picture for the independent mental health services from the State of Care report for 2016 shows that 4% of independent services were outstanding, 73% were good, 22% required improvement and 1% were inadequate. Last year, the ratings were really quite different. Outstanding was at 4%, but good was only 27%, so there has been quite an improvement there. 22% required improvement this year, as opposed to 64% last year. And last year, 5% of those services were inadequate. Priory Hospital Dewsbury is an independent location provided by the Priory organisation. It delivers mental health, long stay and rehabilitation services and older people's mental health, specialising in dementia and delivering care and treatment for neurodegenerative conditions. Priory Dewsbury was inspected in November 2015 and rated overall as requires an improvement and inadequate in the safe domain. This was re-inspected in November 2016 and wasn't re-rated. However, we confirmed that the service was compliant with an action plan for all our regulations following the earlier inspection. At our most recent inspection of Priory Dewsbury, in July last year, we rated the location as good overall, good in safe, effective, responsive and well-led, and it was actually outstanding in the caring domain, so there was significant improvement in that service. Since that inspection, that first inspection in 2015, we've had good ongoing engagement with this service and oversight of their action plan, and it is a credit to their hard work, the achievements that they have made. So key themes that have emerged from our ongoing inspection activity of all mental health services that we're concerned about and that we will focus on in the coming year are too many patients in long stay and rehabilitation services are in services a long way from home, and we really feel it's important that services should be nearer to home. More than 3 years after the publication of the guidance from the Department of Health on positive and proactive care and reducing the need for restrictive interventions, we've seen some good practice. However, there's still a wide variation on the use of restraint on patients and how this is recorded. 7 years after the NHS issued guidance to eliminate mixed-sex accommodation in all hospitals, some services still have mixed-sex accommodation, which has raised concerns around sexual safety for patients with a mental health condition or a learning disability while on the wards. The impact of poor clinical recording systems on patient care, including effective care planning and time with patients, is an issue. And the Transforming Care agenda is tasked with ensuring that people in England with a learning disability or autism are only admitted to hospital when that intervention is most suited to the needs at that time. Hospitals should never be considered as home for people with learning disability. However, contrary to the Transforming Care programme, some patients with a learning disability have been in hospital for a long time, and their care plans appear to lack evidence of active discharge planning. One of the goals of the 5-year forward view for mental health is that by 2021, at least 280,000 people with severe mental health problems should have their physical health needs met. There was a mixed picture in relation to physical health care for people with a mental health condition or learning disability in services, and this is an area that we will be focusing on over the coming year. In the Mental Health Directorate, we also inspect substance misuse services. We don't rate substance misuse services. However, we do intend to start rating those, and hopefully later this year. There are 4 registered Lifeline substance misuse service locations across Kirklees. These were re-inspected in May 2017, and all the concerns around governance which we had identified in an earlier inspection in October 16 had been rectified. However, that service provision is not provided by Lifeline anymore. It's now provided by Change, Grow, Live. We yet to inspect any of the services provided by Change, Grow, Live. We're currently in the process of working with them to make sure that we register their locations, and we will be looking to inspect throughout the year 2018-19. We have more recently inspected the Locala substance misuse clinical provision at these locations. The provision was inspected in November 2017, and the report was published in January of this year. All 4 locations complied with our regulations, and had it been rated, the clinical provision would have been good overall and good in all domains. And that's it for mental health. Thank you.
Thank you very much. Does the panel have any general questions they wish to ask at this time, Dave?
Yeah, if I could just ask, it's on the first slide that referenced the tipping point. I just wonder if you could say a little bit about what you feel the implications of the tipping point are. Once it's tipped, what happens next? And what are your expectations for these sort of key overall issues over the next 3 to 5 years?
Right, that's a big question. The tipping point related to our findings in 2015-16, when we just started off on our new approach. And I think that I referred to it in the presentation as being a wake-up call for providers, because we had ramped up our inspection method, and rightly so, it needed overhaul. I think that since that time, what we're finding is that the inadequate services, I mean, the national picture is better than the picture locally. However, you can't just look at this local authority in isolation, but actually looking at the other local authorities, there are, we're not so far away in terms of their ratings. We kind of give or take 3% or so. It's sort of, it's kind of very similar, because I think the pressures in the north are kind of similar. I think that now that providers have understood our new approach, and that's happened through obviously the information that we're putting out there for providers about actually how they need to be achieving the fundamental standards of the regulations, but also having conversations with providers. So when providers have recurrent require improvement ratings, but also every time a service is rated inadequate in the patch, I will meet with the provider and with the inspector who's conducted the inspection and share that message really about improvement with the provider and the registered manager in attendance. And I think that those conversations have really facilitated improvement, because most services are beginning to improve from that inadequate rating as we're going back. And I think it's been a sea change that people have had to get their heads around, particularly single-handed providers as well, who, like I was sort of describing, haven't had access to some of the privileges of the bigger providers who have like quality managers and compliance departments services which are starting to fail. So I think those things are making an impact, but also because we are having a lot more contacts and it is producing a lot more notifications and inquiries for inspectors to follow up, because you'll perhaps be familiar with our website where you can share your intelligence about services, which is very easy to access, and there's our telephone contact centre as well where you can ring up and share that information over the phone if you haven't got access to IT. And that really is the amount of people who are contacting us with that information is really ramping up year on year. And although it's keeping us busy, what it's also doing is providing us with more intelligence. So it means that we can be more proactive and bring inspections forward and act on that intelligence. So I think that the additional intelligence, the awareness of providers about the expectations, and the quality matters, the conversations that we have with the local authority as well. I think it was December, we called an emergency meeting really to discuss embargoes on services that we had placed on the inadequate services, because we were faced across the footprint of health and social care services a problem with flow through the system, because adult social care, because everyone thinks about hospitals as being the key issue in terms of provision, problems with the winter pressures, but actually the problem exists in adult social care, because if there are services that exist for people to be actually placed into, and those people flow through the services more effectively, then it means it frees up the hospital beds. So I think that those joined up conversations and having an understanding of what's happening across the footprint, across commissioners, providers, ourselves, those joined up conversations are helping to ease the pressures. So the tipping point was a historical context, really, recent history, and it's not going away in terms of the ageing demographic that we have, but I think in terms of where services are in understanding our new approach to regulation, they're getting there in a way that 2 years ago they weren't.
Okay, thank you. Can we just ask social care to come in, how you are working with the CQC, if you could outline that please. And also part of the information was that to encourage improvement as well, because we see the CQC very much as the inspection body, but where do we see that encouraging improvement? So how the local authority is involved with that as well, please. Thank you.
Of course, yes. Just to add to what Helen has said, I think in terms of the tipping point and the wake-up call for all stakeholders involved, it means that we're trying to redefine the relationships now. And I think partly that's about redefining the relationship and strengthening it with CQC and also the provider market, but also redefining the relationship with users, so consumers of care. What that means for social care is that we're now entering into a more early support space or a more preventative space. So where previously we were reacting to crises situation, Helen alluded to what is referred to the CHESP meeting or the CHESP group, and that's an acronym for the Care Homes Early Support and Prevention Group. So we now have clear roles and responsibilities allocated across the partnership, includes CCG colleagues from public health and CQC, where we bring intelligence together at an early stage and get a view of where are some of those concerns, early concerns around providers, and what action do we therefore want to take so that we're not entering into a sort of enforcement stage at all, or an enforcement space, but actually we're having conversations with our commissioning colleagues about best practice, any ongoing support that the care home sector will require, and then, looking at sustainability plans that the care home sector will have and support that they require to meet their performance improvement plans with Kirklees. I also want to add that the Quality Matters initiative, which is a system-wide collective ethos around improving quality, Kirklees Social Care are absolutely well cited on that. It informs our work and our sort of strategy for quality improvement, and therefore the key stakeholders that I've mentioned, CQC, Public Health, CCG, etc., are all key to that. And that will help engineer our sort of 3 to 5 year plan around how we support the sector in quality improvement.
Yeah, but, I was also thinking the tipping point in the context of capacity. So if we've got home closures, if we've got rising demand, we've got falling income to spend on this area of service, that to me implies a tipping point at some point.
Absolutely, Councillor. I think you make a very valid point there. I think all these things are almost like a sort of combination of pressures in the system, and the approach that's been taken now. So you will have heard a few weeks back about the new care offer the Council is investing in, which is more about looking at services and support and intervention that is more upstream. So we're talking about how we're very clear about our narrative with service users and carers, about the early intervention support that the Council is providing to service users and carers. So we're using that as a means of managing that demand. But of course we recognise that there are still cohorts of the population that have very high complex needs. And it's about ensuring that the market has got a sufficient range of high quality, good choices available for people when they require that at a later stage in life. And Helen, you alluded to, I think that consumers and service users are taking a choice now, which is to stay at home and to stay at home with good quality services. So when they reach the point at which they require those critical services in a care home facility, our responsibility is around ensuring that they've got good choices and high quality care available, and that's part of all the work that's being done here.
If I could focus on primary medical services, please. I just wondered if, the information about GPs is very interesting, and I'm surprised the out-of-hours service audits as well as it does, because often what we hear is that out-of-hours services convert their problem into those of the A&E department. But putting that aside, I wondered how much reliance or how prevalent clinical audit is in general practice in this part of the world.
Yeah, thank you. Clinical audit is certainly something we look at when we go in to do every comprehensive inspection of a GP practice involves a look at clinical audit. We see some very good examples and see some practices who do significant amounts of clinical audit and are able to demonstrate significant improvements to patient outcomes. We likewise see some where it is more limited. So it's very much, there's not a general picture, it's very much on a practice-by-practice basis. We tend to report on clinical audit activity in the effective key question in our inspection reports. And there's also reference to it in the well-led section as well, because it kind of sits in both areas in terms of systems and processes and also the actual activity itself. So the answer to your question is it's variable from practice to practice.
And what about the performance of single-handed practices?
I think single-handed practices do face some quite different challenges to the larger practices. I don't think in this particular area across West Yorkshire, certainly as a whole, there's any particular pattern in terms of it being significantly better or significantly worse than a practice which is of a larger size, which includes a partnership. I think that's, again, it's very much on a case-by-case basis. We do have some very, very high-performing and very well-led single-handed practices, as alongside some which do require some improvements to be made.
And does, please, the primary medical service inspection, does that extend to other organisations with whom GPs work closely, like Locala?
We do have some, we do have some GP services that are run by Locala, so there is already some engagement with them there. We also have relationships with colleagues internally who hold the relationship for Locala, which is our hospital's inspection directorate. So yes, we do engage with other services, and we also engage when inspectors are preparing for inspections. They'll speak to care homes which are serviced by the GP practice. They'll speak with health visitors, midwives, a wide range of different stakeholders.
Can I ask a question about working with partnerships? Because a number of services now are provided across organisations, but CQC just seem to inspect an organisation, if you see what I mean. So, for instance, in mental health services, there could be various partners involved in providing services, but you're just inspecting South and West Yorkshire Mental Health Trust and the other sort of organisational hospital services. How do you get a picture of that whole service provision that you're inspecting as part of that?
I'll try and answer that for you. For example, some of the community teams in South West Yorkshire have social workers seconded in from local authority, and we will inspect that community team despite where staff are employed, substantively employed, if you like. Where staff are not substantively employed and they work in partnership, we will consult with stakeholders. We may go and inspect a partner organisation separately and comment on it in a report, but we do consult with stakeholders in partnership when we're doing inspections. But yes, I do take your point that we do inspect one, in silo.
And do you take on board as well, do you look for any scrutiny reports that may have been undertaken in the recent past on the service that you're inspecting?
I can't answer that question in relation to Calderdale and Kirklees because it's not my area. I can ask Kate to respond to that via email if you would like me to. Yes.
In regards to dental services, you mentioned obviously we've got 66 practices that are running, and they are some of them which are NHS and some of them are private. In terms of local national trends as well, we're having a lot of unregistered patients there now, and I know definitely it's in Kirklees as well. Do we have any work, or do you have any work going on to find out if you can actually do more checks, really? Because I think somewhere along the line we're missing whether these locations are at capacity, and we've got patients not being looked after in that sense.
Sure, yeah. I mean, it's something that we're very aware of with the access for patients in the Kirklees area. The CQC obviously believe, as we all do, that anyone who needs an NHS dentist should be able to get one. And the practices we're going to are that full capacity. They've got a set amount of units of dental activity which they have to get each year, and if they don't get any more, then they can't see any more patients. It's something that our national advisor is involved in. It's the NHS contract reform, which is something that's been bubbling along for the past couple of years, and hopefully when that comes in, it will hopefully offer more accessibility for such patients, and also that Healthwatch Kirklees are starting doing some work about something called recall matters, which is dental patients are recalled at different intervals according to the risk of each patient. So a patient who's quite high risk, who's got poor oral hygiene, who suffers from decay, comes back more frequently. And then someone who's got better oral hygiene, who's got lower incidence of decay, comes less frequently. So what Healthwatch are trying to do is to ensure that the dentists in the area are following these guidelines which are initiated by NICE, to hopefully identify the patients who are good and low risk, to see them less frequently, so 9 months to a year, which in theory will open up appointments for unregistered patients to access that treatment. So I said Healthwatch Kirklees are on board with that and looking into that at the moment.
So how are you now encouraging, the locations to actually, if they're not registered on any particular system, to say that you're going to have any auditing or anything like that to them, and you're only auditing, like I said, 10% of them throughout the year. How are you encouraging these particular practices to actually come in? What communications are being done to be able to encourage that to happen?
Do you mean for taking on new patients?
Yes, not just taking on new patients, but actually having a safe level of care, basically, as well.
Sorry? They should be, yes.
And only 10% out of them you'll go out to see. I'm just trying to see the other 90%. They've got what's driving them. The other 90% to actually follow. If you've got no guidance apart from the NICE guidance, what's actually encouraging them to actually have a so with hospitals, with mental health care, we've got a robust plan in terms of measurements of what safety and what level of care we're providing for patients there. But if the other 90%, if in 2 years we've only kind of looked at 13 people out of 66, I'm just trying to see. There seems to be a large number of people that
haven't been inspected. Yeah, I mean, it's the places that haven't been inspected. They should be following the fundamental standards anyway in our regulations. Even though we might not go out to them because we only do 10% a year. But I said if the risk comes in through concerns from patients, whistleblowers, from NHS England or General Dental Council, then we will go out and inspect them.
I think the concern is that because you're only doing 10%, if something changes in that practice and your level of risk has not, you don't have any intelligence about that, how is the level of risk being assessed? Because some of the practices haven't been inspected for a few years. So how do you how is it the other practices? How is the assurance there that they are maintaining their level of care? I think that's what is being asked. Yeah. If you want to come back to us, then that's fine. But I think we'll close the formal meeting there. Thank you very much for your presentation, and we'll close our meeting. Thank you, Richard.